starting. So who will be presenting today?
Doctora Bupati's group.
Okay, so today we'll have our SGD. We'll just be watching the remaining group present their infographics, and hopefully this would also help you with your final exam next week, right? Next week, my final exam. Yeah. So yeah, let's wait for the first group to prepare. Can we start? Sure, you can start now. Okay. Okay, so our group will be doing a small discussion of basal cell carcinoma. Good morning, ma'am. So first is basal cell carcinoma. It is a type of skin cancer. It is a type of skin cancer. So it begins in the basal cell. So basal cells is a type of cell within the skin that produces new skin cells as old ones die off. And it often appears as a slightly transparent bump on the skin, though it can make other forms. And it occurs most often on areas of the skin that are exposed to the sun, such as head and neck. And most basal cell carcinomas are thought to be caused by long term exposure to ultraviolet radiations from sunlight. And avoiding the sun and using sunscreen may help protect against basal cell carcinoma. And the signs and symptoms and the clinical manifestations of basal cell carcinoma are approximately 85% of BCCs occur on the face and head, scalp included, and neck, and others appear on the trunk or extremities, and it rarely occur on the hands. And these signs and symptoms includes waxy papules with central depression, pearly appearance, and erosion or ulceration, often central and pigmented, and bleeding, especially when traumatized, or oozing or crusted areas, that is especially large BCCs, translucency, and telectasis over the surface, and it is a slow growing. That is, for example, it's 0.5 centimeter in 1 to 2 years, and it's a small pink or red. It will be appear as a small pink or red shiny bumps that may have black, blue, or brown areas, and it has a rolled or raised border. And this rolled or raised border is one of the main characteristic to differentiate BCC from other diseases. So this picture here shows the different types of BCCs, and the first one here shows the pink or translucent pearly bumps, which might have blue, brown, or black areas, and the second one has the pink growth with raised edges and a lower area in their center with abnormal red blood vessels spreading out. And the third has a pale or yellow area similar to a scar, and here it is raised reddish patches, and it is an open scope that doesn't heal, which may have oozing or crusted areas. So the risk factors that are included in BCCs are first is chronic sun exposure, that is intermittent sun exposure as identified by prior ones. So a lot of time spent in the sun or in commercial tanning beds increases the risk of BCCs. And the next is radiation therapy. So radiation therapy to treat acne or other skin disease conditions may increase the risk of BCC at the previous treatment sites on the skin. And the next risk factor is a positive family history of BCC, and the next is immunosuppression. So, taking a medication that suppresses immune system, such as anti-injection drugs used for transplant surgery, they significantly increases the risk of BCC. And next is a fair complexion, especially red hair. And the next is age. So, as I said before, BCC takes it's a slow growing it's it develops very slowly, so it often takes decades to develop. So the majority of BCC occur in the older adults, but it can also affect younger adults and is becoming more common in people in their 20s and 30s. So the next risk factor is blistering syndromes in childhood. The next is smoking, and next is exposure to arsenic or hydrocarbons. So arsenic, it is a toxic metal, but there is arsenic is found widely in the environment. So everyone will have some exposure to arsenic as it is widely in the environment. But some people may have higher exposure if they drink contaminated well water or have a job that involves producing or using acid, like glass factory, glass making, mining, etc. So they have increased risk of having BCC. And the next is indoor tanning. It is a strong risk factor for early onset of BCC, particularly among women. So this is the anatomic risk areas. So the red one shows the high risk areas. There is central face, eyelids, eyebrows, periorbital skin, nose, lips, chin, mandible, periauricular, and post-auricular skin, temple area, ear, genitalia, hands, and feet. And the yellow here shows the medium risk areas. There is cheeks, forehead, scalp, neck, and peritibial. And the green here shows the lower risk areas. There is trunk and extremities, excluding hands, feet, nail units, peritibial area, and ankles.
So, good morning, everyone. I'm going to present histological subtypes of basal cell carcinoma. More than 26 different subtypes of BCC appear in the literature, but the most common distinctive clinicopathological types include nodular, micronodular, superficial, morphiform, infiltrative, and fibroepithelial, also known as fibroepithelioma or pincus. Combination of these types can occur as well. So first I'm going to discuss about subtype nodular basal cell carcinoma. Description: most common type of facial BCC, shiny or pearly nodule with a smooth surface. May have central depression or ulceration, so its edges appear rolled. Blood vessels across its surface. Cystic variation is soft with jelly-like contents. Micronodular, microcystic, and infiltrative types of potential aggressive subtypes, also known as nodulocystic carcinoma. Next, please. So next type is superficial BCC. Most common type in younger adults. Most common type on upper trunks and shoulders. We can see in the pictures. Slightly scaly, irregular plaques. Thin, translucent rolled borders. Multiple micro erosions. The lesion enlarge very slowly and may be misdiagnosed as patches of eczema and psoriasis. They may grow to be 10 to 15 centimeters in the diameter. Close examination of the edges of the lesion will show a thread-like raised border. This form of BCC is the most common pattern seen in patients with HIV infection and BCC. Next slide, please. So next type is morphiform or cicatricial BCC, usually found in mid-facial sites. Waxy scar-like plaque with indistinct borders, wide and deep subclinical extension. May infiltrate cutaneous nerves, the perineural spread. Also known as morphiform or sclerosing BCC. Yet the unique histological feature is the strands of basal cell interspace amid densely packed hypocellular connective tissues. Basosquamous carcinoma. This is a mixture of BCC and squamous cell carcinoma. Infiltrative growth pattern potentially more aggressive than other forms of BCC. Also known as basosquamous carcinoma and mixed basal squamous cell carcinoma. Next slide. Micronodular basal cell carcinoma. Another aggressive variant, micronodular BCC, appears as small nodular aggregates of basaloid cells. These tumors are not clinically distinctive, but the micronodular growth pattern makes them less amenable to curettage. Next slide. So next is infiltrative BCC. This specific type presents than other BCC in that it is formed in thin, small clusters, making it less apparent to spot. Clinically, it lacks the scar-like appearance of morphiform BCC. Histologically, the stroma is hypercellular, the islands are jagged in outline, and squamous differentiation is common. Next slide, please. So, fibroepithelioma or Pincus. First described by Pincus as pre-malignant fibroepithelium tumor. This is usually an elevated, skin-colored, sensile lesion on lower trunk, lumbosacral area, groin, or thigh, may be as large as 7 centimeters. The lesion is superficial and resembles a fibroma or papilloma. As the infundibulocyte BCC, fibroepithelioma is composed of pink epithelial strands with blue basaloid buds. Fibroepithelioma often demonstrate sweat ducts, and within the pink epithelium cell strands, simple removal of excision or electrosurgery is the treatment of choice. Next slide, please. So, rodent ulcer, also known as Jacobi ulcer. Rodent ulcer is a neglected BCC that has formed an ulceration. The pearly border of the lesion may not be recognized. It is on the lower extremity. It may be misdiagnosed as a vascular ulceration. So next, pigmented basal cell carcinoma. The variety has all the features of nodular BCC, but in addition, brown or black pigmentation is present. It is seen when dark complex person. This is the type they tend to develop. In the management of these lesions, it should be known that if ionizing radiation therapy is chosen, the pigmentation remains at the site of the lesion. Next slide, please. So, pore-like basal cell carcinoma. Patients with thick sebaceous skin of the central face may develop a BCC that resembles an enlarged pore or stellate pit. The lesions virtually always occur on the nose, malolabial fold, or lower forehead. Affected patients are generally men, and majority are smokers. So, polypoid basal cell carcinoma. The polypoid BCC is present as exophytic nodules of the head and neck. Next slide, please. So, aberrant BCC. Even in the absence of any apparent carcinogenic factor, such as arsenic, radiation, or chronic ulceration, BCC may occur in odd sites, such as the scrotum, vulva, perineum, nipple, and axilla. Solitary BCC in young persons. These curious lesions are typically located in the region of embryonal clefts in the face and are often deeply invasive. Complete surgical excision is much safer than the curettage for the removal. Cases in children and teenagers associated with the basal cell nevus syndrome or nevus sebaceous are well documented.
Good morning, Doc. Good morning, everyone. So, moving on to the etiology and pathogenesis, it appears that BCC arise from immature pluripotential cells associated with the hair follicles. Mutations that activate the Hedgehog signaling pathway, which controls cell growth, are found in most BCCs. DNA mutation in the patch tumor suppressor gene, part of Hedgehog signaling pathway triggered by exposure to ultraviolet radiation. Inactivation of patch 1 is most common, and SMO mutations are associated with 10 to 20% of sporadic BCC. Next, please. So, moving on to the Hedgehog signaling pathway, the Hedgehog signaling pathway can cause basal cell proliferation and tumor growth. Signaling in this pathway is initiated by the cell surface receptor smoothen hormone, which is the SMO. In adults, this pathway normally is inhibited by another cell surface receptor, the patched homologue 1, PTCH1. Binding of the Hedgehog ligand to PTCH1 prevents this inhibition. There are two mechanisms have been identified by which the Hedgehog pathway may be involved in the pathogenesis of basal cell carcinoma. So, first one include mutations in PTCH1 may prevent inhibition of SMO activation of the Hedgehog pathway. And the second one include mutation of SMO may result in constitutive activation of the pathway. This picture shows the mechanism of action of the Hedgehog pathway. Next, please. So, the epidemiology, basal cell carcinoma is the most common human malignancy. It is particularly common in white populations. It is very uncommon in darker skinned populations. In white populations in the United States, the incidence of BCC has increased by more than 10% per year, and the lifetime risk of developing a BCC is 30%.
So next is histopathology. So early lesion may show as a small dark staining polyhedral cells with large nuclei and small nucleoli, and these occur within the epidermis as thickenings or immediately beneath the epidermis as downgrowths connected with it. And at the periphery of the muscles of cell, the columnar cells may be characteristically arranged like fence posts, that is palisading, that is shown in this picture. Uh, and this may be absent when the tumor cells are in cord arrangement or in small nest. Nest are also here in page. And cysts may also form, and the interlacing strands of tumor cells may present a lattice-like pattern, which is this. This is a lattice-like pattern, and the dermal stroma is an integral and important part of the BCC. And the stroma is a loose and fibromaxoid with a space lymphoid infiltrate often present. And the stroma can be highlighted by metachromatic toluidine blue staining, which can be useful during Mohs surgery.
Good morning, everyone. Here we are in differential diagnosis. We have basal cell carcinoma, squamous cell carcinoma, and melanoma. Here the thing is, it is most similar the first thing, which is known as the most common sun-exposed area, and we can differentiate with the lesion spots or lesions. The first one is basal cell carcinoma, which is the reddish tan and pale to bright pink, pearly white or skin color, as well as you can see the picture. I mentioned it. Then sometimes it may be brown and black lesions may can appear. In squamous cell carcinoma, whitish pink or brown may be appear. In melanoma, grayish blue, bluish white veil, also black or brown dots may also appear. Here the thing is that we can differentiate with the nodular. The basal cell carcinoma has the variant of a waxy nodular rolled edge. In squamous cell carcinoma, a dome-shaped bump that look like a wart. Also, the red scalpy patch of the skin that it's rough, crusty, and bleed easily. In melanoma, it is an asymmetrical shaper. It is possible or uneven border may be noticed. Next slide. Okay, next move on to the diagnostic test. Here we have two options. The first one is skin exam. We have to examine the signs for the skin abnormal growth, including the size, color, shape, and also the textures. Then skin biopsy. There is a 3 biopsy here we have. The first one is shave biopsy by using tubular material, to remove the razor. Small section of the top layer, such as epidermis to the portion of the dermis, we have to remove. And the next one is punch biopsy by using the circular tool to remove the small pore of the skin, including the deeper layers, epidermis, dermis, and superficial fat. The third one is excisional biopsy by using a small knife scalpel to remove an entire lump and an abnormal skin, including the portion of normal skin, down to the through the fatty layer of the skin, as well as I posted these pictures. Next slide.
So next is staging. So staging, staging is the process of determining whether the cancer has spread, and if so, how far. And the stage of the disease may affect the stage of the disease may affect the treatment plan. So the staging is based on the size of the tumor, how deeply into the skin it has grown, and whether the cancer has spread beyond the tumor to the lymph nodes. So there are 5 stages. The first is stage 0. So stage 0 is also known as carcinoma in situ, as it's only found in the original tumor in the skin. So cancer is found only in the original tumor in the skin. So it is only in the epidermis and it has not spread to the dermis. So it is called carcinoma in situ. So next stage 1 is stage 1. In this stage 1, the tumor is the size of the tumor will be less than 2 centimeter, and it will be limited to the skin only. It doesn't spread to any other organs. And the next stage is stage 2. Its tumor will be greater than or equal to 2 centimeter, and it will also be limited school and also subcutaneous adipose tissue. And so the third stage is the tumor could have already be invased to muscle, cartilage, bone, lymphatics, and perineural invasion. But it has only spread to those near the original tumor, not spread to the distant organs. But stage 4, it has already spread to the metastasis to the distant organs like brain or lungs, or has invaded the skull or perineural invasion of skull bases. So this is risk assessment of BCC. So once the workup is completed, that the diagnosis is completed, a risk assessment of BCC should be done, as it should be divided to low risk tumor or high risk tumor, so that which can help to determine the correct treatment options. So the factors that differentiate whether BCC is low risk tumor or a high risk tumor are: first is clinical. The first is location or size. So location or size, the area L is trunk and extremities, excluding hands, feet, nails, ankles, and tibia. So the area should be, if the size is less than 20 millimeter, then it is a low risk tumor. But if it's greater than or equal to 20 millimeter, then it becomes high risk. And if area M, that is forehead, cheeks, scalp, neck, and pretibia. So if the size is less than 10 millimeter, then it's low risk tumor. And if it's greater than or equal to 10 millimeter, then it's a high risk tumor. And area H, that is facial mask areas, hands, feet, and genitalia. If the tumor is in these areas, then it's already a high risk tumor. The next clinical characteristics, borders. So if the borders are well defined, then it is a low risk tumor. And if it's poorly defined, then it's a high risk tumor. And primary versus recurrent. So if the tumor is a primary tumor, then it's a low risk. And if it's a recurrent one, then it's high risk. And for the immunosuppression, if immunosuppression is present, then it's a high risk. And if no immunosuppression is there, then it's a low risk. And site of prior radiation therapy. If it's in the site of prior radiation therapy, it's a high risk. And if it's not in prior radiation therapy site, it's a low risk. So next is pathological characteristics. So growth pattern. If it's nodular and superficial, then it's a low risk. And if it's an aggressive pattern, then it's already a high risk. And next, perineural involvement. If there is perineural involvement, then it's a high risk. And if there's no perineural involvement, then it's a low risk.
Good morning, Doc. Next, we are going to the treatment. Treatment for BCC depends on the age and gender of the patient, as well as the size, location, and type of the lesions are important factors to be considered when choosing the proper method of treatment. The goal of treatment for basal cell carcinoma is the elimination of tumor with maximal preservation of function and physical appearance. Next slide. So first one is surgical removal. There are 3 types of surgical removal used to treat BCC. The type of surgical removal depends on the type of BCC, where it's located, and how deeply it goes. The first one in surgical removal is excision. Excision is the removal of skin cancer along with the sum of the healthy skin tissue around it. It's most appropriate treatment for nodular, infiltrate, and morphoid BCC. It might be recommended for basal cell carcinomas that are less likely to recur, such as those that form on chest, back, hands, and feet. Next slide, please. So next is Mohs surgery. So Mohs surgery is a precise surgical technique used to treat skin cancer. During Mohs surgery, the thin layer of cancer containing skin are progressively removed and examined until only cancer-free tissue remains. Mohs surgery is also known as Mohs morphographic surgery. So it involves examining carefully marked exist tissues under microscope layer by layer to ensure complete excision. It might be recommended if basal cell BCC has a high risk of recurring, such as if it's large, extends deeper in the skin, or is located on the face and used in high risk areas of the face around eyes, lips, and nose. Here's a picture. Okay, next slide. Next is curettage and electrodesiccation. So it's a basic skin procedure in which the technique of curettage use a sharp curettage is followed by electrodesiccation. It's a surgical procedure used to remove the certain skin lesions such as warts, angiomas, acidic keratosis, basal cell skin cancer, and squamous cell skin cancer. Scrapping or burning of skin growth can be used for less serious skin cancer, precancer, and benign growth. A local anesthetic is injected and then the abnormal tissue scraped off with a special tool. This is suitable for small, well-defined nodular and superficial BCC. The lesions are mostly located on the trunk or limbs. So at the last, the wound is left open to heal by secondary intention. Moisture wound dusting lead to healing within few weeks. Next slide, please. Next is cryotherapy. So cryosurgery is a treatment that uses extreme cold produced by liquid nitrogen or argon gas to destroy cancer cells and abnormal tissue. It is used to treat tumors on the skin as well as certain tumors inside the body. It's suitable for small superficial BCC on covered areas of trunk and limbs. It's best avoided for BCC on head, neck, and distal to knees, which result in a blister that crusts over and heals within several weeks. So the radiation therapy uses high energy beams such as X-rays and protons to kill cancer cells. It can be used to treat primary BCs or as adjunctive treatment if margins are incomplete. Radiation therapy is sometimes used after surgery when there is an increased risk that the cancer will return. It's best avoided in among young patients and in genetic conditions predisposing to skin cancer. Next slide. Next is photodynamic therapy. PTD refers to the technique in which BCC is treated with a photosensitizing chemical and exposed to light several hours later. Topical photosensitors include aminoluvenic acid lotion and methyl aminoluvenic cream is used. It is suitable for low risk small superficial BCC. Best avoided if the tumor is in the site at high risk of recurrence. Next is topical therapy. Topical therapy appears to be most effective in the treatment of superficial BCC. For nodular BCC, the cure rates are only 65%. On the other hand, superficial BCC may be cured 80% of the time with the topical treatment. Several topical creams are used in the management of BCC that is non-recurring and superficial. So here the first one is topical 5 fluorouracil cream may be used to treat small superficial BCC in low risk areas. The topical 5 fluorouracil applied twice daily for at least 6 weeks can yield acceptable results in properly selected thin tumors with high recurrence rate. Next is Interferon Alpha 2B, is a protein product manufactured using recombinant DNA technology. It has shown some success in treating small, which is less than 1 centimeter, nodular and superficial BCC. In appropriate BCC tumors, cure rates of up to 80% have been obtained. Next slide. Imiquimod is an immunoresponse modifier best used for superficial BCC less than 2 centimeter diameter, applied 3 times a week with occlusion or 5 times a week without occlusion. Is a favored form of topical patient applied treatment for a superficial BCC. The duration of treatment is 6 weeks but may be extended if the lesion do not appear to have been eradicated. Next is tazarotene, the receptor selective acetylenic retinoid tazarotene can also be used to treat small low risk BCC. Is thought to cause BCC regression by increasing apoptosis and by decreasing cell proliferation in the skin cancer cells. Treatment for cancer that spread, it's very rarely the basal cell carcinoma may spread to nearby lymph nodes and other areas of the body. The additional treatment options are targeted drug therapy. Targeted drug treatments focus on specific weakness present within cancer cell. By blocking these weakness, target drug treatments can cause cancer cell to die. The targeted therapy drugs for BCC block molecular signals that enable the cancers to continue growing. They might be considered after other treatment or when other treatment aren't possible. Next is chemotherapy. Chemotherapy uses powerful drugs to kill cancer cells. It might be an option when other treatments haven't helped. Next slide, please. Next is the complication of BCC. The first one is recurrent BCC. Recurrence of BCC after initial treatment is not uncommon. Characteristic of recurrent BCC often includes incomplete excision or narrow margins at primary excision, morphoic, micronodular, and infiltrate subtypes, location on head and neck. Advanced BCC, it's large. They are large, often neglected tumors. They may be several centimeters in diameter, deeply infiltrating into tissues below the skin and are difficult or impossible to treat surgically. Next is metastatic BCC. So it's very rare. The primary tumor is often large, neglected, or recurrent, located on head and neck with aggressive subtype. It may have multiple prior treatments and arise in site exposed to the ionizing radiation.
Doc.
Okay, we can proceed with the next group. I'll just give my inputs after the topics. I think for the first group, medyo mahaba, no? Okay, sige, you can proceed.
So good morning everyone. This is our 3-page infographic for squamous cell carcinoma. So for squamous cell carcinoma, so it's a type of a non-melanoma skin cancer, which is the second most common form of non-melanoma skin cancer behind your BCC. So the major risk factor for SCC is your chronic long-term exposure with other risk factors such as your immunosuppression, your HPV exposure, especially your 16 and 18, your chronic ulcers, chronic inflammatory disorders, your hidradenitis suppurativa, to name, and your radiation and your Suralin ultraviolet A therapy for psoriasis. So for the clinical features of SCC, SCC begins at the site of your actinic keratosis. These are your precancerous lesions. That is your sun-exposed areas, particularly at the face and the back of the hands. So earlier lesions would present superficial, discrete, and hard, arising from an indurated, rounded, elevated base with a dull red and telangiectatic appearance. It is localized and freely mobile. And furthermore, it will improve, or it will after some time it will grow larger, deeply nodular and ulcerated, diffuse, depressed, and fixed, as shown on the left pictures. So once the lesions have been established, it would invade underlying tissues, and advanced lesions would present as cauliflower-like, composed of densely packed filamentous projections, between which are clefts filled with a viscous, purulent, and malodorous exudate. Next slide. For the epidemiology, for the blacks, it's your squamous cell carcinoma is much more common than your basal cell carcinoma for about 20%, with the face and lower extremities being the most common involved part, with involvement of non-sun exposed areas. On the other hand, for the whites, your SCC can be caused due to your predisposing conditions such as your burns, leg ulcers, and hidradenitis suppurativa, as previously mentioned. So as shown in the picture, so your blacks would present your SCC commonly at the lower extremities, while your whites would present SCC due to your burns, as shown in the picture. Thank you.
Thank you. So good infographic. So I'd just like to highlight the difference between your BCC and SCC. Okay. So for your BCC, review nyo na rin to for your exam. For your BCC, it is the most common non-melanoma skin cancer. Wherein for your SCC, it is the second most common non-melanoma skin cancer. However, it is the most common in patients with immunosuppression. Okay? Take note ha. So most common non-melanoma skin cancer, BCC. SCC, second most common. However, it is most common in immunosuppressed patients. In terms of its epidemiology, one thing to differentiate the two is your BCC is may be caused by your intermittent intense sun exposure, while as your SCC, it is more of your chronic long-term sun exposure. Okay, so BCC intermittent, SCC chronic long-term sun exposure. And of course, for the morphology, so your BCC naman has a distinct morphology, right? So one thing to remember for your BCC is you have your RUT, okay? RUTT. So R stands for your rodent ulcer. Your U is your ulceration. Your T is your translucent papule, or can be your pearly papules. And your T is your telangiectasia. So you have your RUTT as your mnemonic for your BCC. And of course, it was mentioned that the most common type of your BCC is your nodular. However, in young adults, it is your superficial spreading. BCC. What else? So it's important that you know your risk areas for your BCC and SCC because it will affect the management of these cases. Okay? So, good infographic for the second. I think na-misunderstood lang ng first group. However, I appreciate your presentation. Okay? So, both naman have parang mostly the same epidemiology, right? Sun exposure, sunburns. However, for SCC, mostly it can be due to your HPV infection, your scars, your burns, your PUVA, as mentioned by your classmate, for patients with psoriasis, radiation therapy, and both actually has a predilection to those with upper Fitzpatrick skin types. Okay, so thank you and a very good presentation. Of course, for your treatment, you can have your excision, you can have your cryotherapy. However, your most micrographic surgery is the preferred treatment of choice, especially in high-risk areas. Okay, so we proceed to your melanoma. Thank you.
Morning, everyone. We're the group 3 and we're going to present an infographic about melanoma.
So again, good morning everyone. So what is melanoma? So melanoma is one of the most serious types of skin cancer because it has the highest rate of metastasis. So except in the setting of giant congenital nevi, melanomas typically originate from melanocytes at the dermo-epidermal junction, or the DAJ. So remember that almost half will develop in pre-existing nevi, but the rest will develop on previously normal appearing skin. So we have here the ABCD criteria for melanoma. And these are simple for lay individuals to understand and have proved to be helpful for the detection of melanoma. So the letters stand for A, asymmetry. Here, one half of the spot is unlike the other half. For B, it's the border for irregularity. The spot has an irregular, scalloped, or poorly defined border. And for C, stands for color variation. The spot has varying colors from one area to the next,
such as shades of tan, brown, or black, or areas of white, red, or blue. And D is for large diameter. The spot is larger than 6 millimeters across, and it's about the size of a pencil eraser. And lastly, E is for evolving. The spot looks different from the rest or is changing in size, shape, or color. So we have here the clinico-pathologic types of melanoma, which include the first picture is the lentigo maligna, which begins as a tan macule that extends peripherally and even darkening over the years. So this one is more common in older patients with heavily sand-damaged skin and also in sunny climates. And now it appears to be increasing in frequency and is considered now the most common form of melanoma. And then on the right, the next picture is what we call the superficially spreading melanoma. And this one, it's characterized by a backshot scatter of melanocytes throughout the epidermis. And because of this, you can see the borders tend to be more sharply defined than those of lentiginous types of melanoma. So the next picture on the right again, it's the acrolentiginous melanoma, and it's the most common type of melanoma in dark-skinned and in Asian populations. So the most common site of melanoma of this melanoma in Black persons is the foot. So and also the thumb and hallux are more frequently involved than the other digits. Next one is the mucosal melanoma. It's a primary melanoma of the mucous membrane that is rare and typically demonstrates a junctional growth pattern. Next one is the nodular melanoma. And this one now constitutes about 15% of all the melanomas, and primarily on sun-exposed areas of the head, neck, and trunk. And these tumors may be smooth and dome-shaped, as you can see, and can be fungating, friable, or ulcerated. And also with this one, bleeding is usually a late sign already. Next one on the, it's a polypoid melanoma, and this one presents as a pedunculated tumor, and it does not appear to descend for any appreciable distance into the dermis. Next one is the desmoplastic melanoma, and most often occurs on the head or neck of older men, and often within a subtle lentigo maligna. Next one, as you can see, it's the amelinotic melanoma. It's non-pigmented melanoma because it differs from other melanomas because you can see it is the one that lacks pigment. So the lesion here in the picture is pink, erythematous or flesh-colored, and this can now mimic the BCC or granuloma pyogenicum. And it is the it is a type of melanoma that variant that is usually seen in albino persons. And lastly, soft tissue melanoma and sarcoma that occurs more frequently on the lower extremities of young people. Okay, thank you.
Okay,
So,
thank you.
Dr.
You still have, okay. Continue.
So the second question is, who are at risk for melanoma? So according to Fitzpatrick, there is a rising incidence worldwide in countries with white inhabitants, with the highest incident rates in Australia, followed by the North America and Europe. So who are at risk? So the light-skinned people are the Caucasians, and those people who have sunburn or heavy sun exposure, and people who are who have many or unusual moles, and of course the weak immune system, and the mean age of 63 years old, 15% younger, younger than 45 years old, and genetically the CDK2A and 2A and the P16. So the third question is, how does it develop? So there is clear convincing evidence that the sun exposure and more specifically the UV rays is a major environmental cause of melanoma. So in younger men, the most common affected is the trunk, particularly the back. And for the younger women, usually on the lower legs and followed by the trunk are the most common sites. So there is also rising concern over the tanning beds and the melanoma risk because of the exposure to artificial UV radiation. And pathophysiologically, there is DNA damaging and which is carcinogenic, inflammatory, and immunosuppressive properties of UV radiation that can initiate and progress to and metastasize to primary melanoma. So different genes are responsible for the development of inherited melanoma, and there are three mechanisms: the activation of oncogenes, the loss of tumor suppressor genes, and increased chromosomal instability. Next.
For the workup, so the melanoma diagnosis is primarily based on the skin biopsy, but additional diagnostic test is usually required for each stages. So for stage 0 and 1A, there is no need of any additional x-rays or blood work indicated because these are usually confined to the epidermal region of the skin. And for stage 1B or 2, chest x-rays or lactate dehydrogenase test are usually optional, but for stage 3A, we need to do a chest x-ray and LDH according to the NCCN guidelines because stage 3 is already spread to the lymph nodes. And for stage 3B or 3C, we need to do a fine needle aspiration to confirm if there is any nodal involvement, and chest x-ray is also recommended. For stage 4, it already started to spread to other organs. So we need to make test for abdominal and the pelvic CT scan along with head MRI or a positron emission topography. Next.
So for the treatment, the main treatment for melanoma is surgical removal or excision of the primary melanoma on the skin. The extent of the surgery depends on the thickness of the melanoma. Most melanomas are found when they are less than 1 millimeter thick, and outpatient surgery is often the only treatment needed. A doctor removes the tumor tissues found under the skin and some surrounding healthy tissue called a margin so that no cancer cells remain. If a sentinel lymph node biopsy is also needed, it is usually done at the same time with the excision. So we also have here the different drugs for melanoma, namely the imatinib, ipilimumab, nivolumab, pembrolizumab, and vemurafenib. Thank you.
So much po, Doc.
Okay, so done na. So for melanoma, what you need to remember lang talaga is the ABCDs, your asymmetry, your border, your color variegation, and diameter more than 6 millimeters. And then, one thing to remember na lang yung mga subtypes of melanoma kasi mostly naman would actually be due to sun exposure. However, para medyo maalala nyo, so for your superficial spreading melanoma, so as mentioned a while ago by your groupmate, di ba intermittent sun exposure lang. So your mnemonics for that is, di ba, SSM, so sometimes maaraw, okay? So intermittent exposure, superficial spreading melanoma. What else? Your LM naman, your lentigo maligna. So your sun exposure, heavily sun exposed skin. So one thing to remember about your LM is laging maaraw, LM. Okay. So what else? For your ALM, di ba, it is the most common type of melanoma in Asian people. So, my mnemonics for that is parang Asian, LM, laging dark skin. So, laging may pink. So, Asian dark skin. So, one thing to remember lang. And then, of course, your treatment depends again on your staging. Okay. So, sige. Nice infographics. Thank you. We move on to hair disorders.
So good morning po. Ay sorry, nakamute pala. So the second is the hair defects. So we have two infographics: the common hair defects, mainly the alopecia, and the hair shaft defects. So for the alopecia, as we all know, it is defined as hair loss. So we have the non-cicatricial alopecias, the cicatricial alopecia, and the other permanent alopecias. So the non-cicatricial or non-scarring, we have the alopecia areata. As we all know, this is a rapid and complete loss of hair that occurs in patches, oval or round-shaped patches. So the cause is it is autoimmune, and the treatment for this is mainly steroids. So the next is the pattern alopecia or the androgenetic alopecia. So we have the male pattern and the female pattern. For the male pattern, this is usually gradual hair loss, and for the female, it is usually diffuse hair loss. The first sign in males would be a whisker or kinky hair, and the cause is usually androgen dependent or increase in androgen. And the treatment is finasteride mainly in male, 1 mg. And for the females, minoxidil is said to be with greater potency than the finasteride. The next one is the telogen effluvium. So this is the excessive shedding of normal telogen club hairs, or as they say, the hair is lost at the root. So the causes are pregnancy or parturition, surgery, dieting or crash diets, and certain drugs. So the treatment would be the usually telogen effluvium with the hairs would regrow spontaneously. However, in some cases, minoxidil can be given to these patients. And the last common is the trichotillomania or trichotillosis. This is a compulsive practice of plucking hairs from the scalp, the brows, and the eyelashes. So this is usually a manifestation of OCD, depression, and anxiety. So the treatment would be focusing on the behavioral modification and therapy. So the next types is the cicatricial or the scarring type of alopecia. So we have DLE, folliculitis decalvicans, and dissecting cellulitis. So for the chronic cutaneous lupus erythematosus, the anagen hairs may be easily extracted from the involved area. So the main cause is the SLE per se. The treatment would be corticosteroids, but systemic therapy for the SLE is the mainstay for this one. So for the folliculitis decalvicans, the crops of pustules can result to alopecic patches as seen in the picture. So the cause is the abnormal immune response to staphylococci infections. The treatment would be main treatment would be tetracycline. However, combination with rifampin and clindamycins are also encouraged. The last is the dissecting cellulite, which is the deep boggy and suppurative lesions that is seen in the scalp. These usually coexist with acne conglobata and hieradenitis suppurativa. So again, the treatment would be tetracyclines, retinoids, and topical corticosteroids. The other permanent disease that cause alopecia would be the traction alopecia and the pressure alopecia. So in the traction alopecia, this is caused by prolonged scalp, mainly the temples and the ears. For the pressure alopecia, this is caused by pressure-induced ischemia, caused by prolonged pressure on the scalp in patients that is bedridden, or in general anesthesia, which is the prolonged one main pressure on the scalp, and other procedures. So always remember to consult your dermatologist for because your hair is their crown of beauty. For the next hair structure defects, the methods to examine hair structure defects would be devised by the Shelley. So again, the procedure the Shelley is they to stabilize the slides, and then they put it in the dermoscopy. SEM is also recommended to diagnose hair structure defects. So first is the hair cast or pseudonitis. So these are the remnants of the inner root sheets. They may mimic nits in the scalp as seen in the picture. And however, this slides freely along the shaft, unlike the nits, which are firmly cemented on the shaft of the hair. The second one is the monolithics, or what we know as beaded hair. The dryness, fragility, and sparseness of the scalp hair with fusiform or spindle-shaped swelling of the hair shaft separated by a narrow atrophic segments. So these are associated with keratosis pilaris of the extensor surfaces, temples, and back of the neck. The third is the trichorexis nodosa. The hair shafts are fractured easily, and the nodes are the sites of fraying of the hair cortex. Splitting into the strands produces a microscopic appearance of suggestive of a pair of brooms stuck together end to end by their bristles. So you should avoid aggressive brushing and other grooming practices which put a lot of physical stress on the fiber of the hair. The last is the trichorexis invaginata. So these are called bamboo hair, ball and socket deformity, and Gulf tree hair. So the intussusception of the hair shaft at the zone where keratinization begins. The invagination is usually caused by softness of the cortex in the keratogenous zone. Ayan po.
So, okay, thank you for your presentation. For something na I think you made last night, nagagaling ninyo. Anyway, for your hair disorders, it is important that you compare and contrast so that you would know how to differentiate each, diba? So I think I've discussed the differences between your alopecia, your androgenetic alopecia, your telogen, and other hair defects. However, I would also like you to focus on your hair structure defects kasi baka matching type pa siya sa exam. Okay? So, take note. So, sige, we proceed with your next topics.
Good morning, everyone. So our group worked on topic number 5, which is hypertrichosis and hirsutism. So this is our final output. For a better view, let's zoom it in. So first, we describe hypertrichosis as simply an amount of hair growth anywhere on the body, and it is also known as the werewolf syndrome. We are also define hirsutism as the excessive growth of thick or dark hair in women in locations that are more typical of male hair growth patterns such as mustache, beard, central chest, shoulders, lower abdomen, back, and inner thigh. Next, please. For the epidemiology, in the majority of hypertrichosis cases, men and women are equally affected with a few exceptions.
Prepubertal hypertrichosis is common in healthy Mediterranean or South Asian infants and children. Hypertrichosis of the auricle and hypertrichosis of the nasal tip and types of hereditary hypertrichosis primarily affect males. So for hirsutism, it affects approximately 10% of women in the United States, and it is one of the most common health problems for women of reproductive age. For the prevalence, 4.3% in Black women and 10.8% in white women, while in Asian women, the prevalence is lower. Polycystic ovarian syndrome or PCOS is the most common cause, which is 75% of cases. Next. Next, please.
Hello, can I be heard? For the etiology, there are a number of causes of hirsutism, such as adrenal disorders, androgenic drugs, ectopic hormone production, familial hirsutism, ovarian disorders, and pituitary disorders. Overall, the most common cause is PCOS or polycystic ovarian syndrome, as said earlier. Etiology for hypertrichosis is usually caused by systemic illnesses, paraneoplastic syndromes, non-androgenic drugs. It also occurs in rare familial disorders called congenital hypertrichosis. Next slide, please.
For the symptoms, there is excessive growth of post-fake hair instead of fine hair in the area which is not in which there is not usually growth of hair, and the deepening of voice, acne, enlarged clitoris can be present, and there is needle pattern barrenness, and irregular periods can be also there.
So are you done with the presentation?
So for the other types of hypertrichosis, congenital hypertrichosis laginosa, this is started as lanugo. So lanugo, as we all know, is the unpigmented fine soft silky hair which covered the baby. So instead of disappearing, it continues to grow in various places on the baby's body.
For the next is the congenital hypertrichosis terminalis. This is fully pigmented terminal hair all over the body, also referred to as the wolfman, werewolves, and apemen. In nevoid hypertrichosis, this is the excessive growth at a limited, isolated, and defined area or body part. And the last one is the acquired hypertrichosis. This develops at later life, which may grow in small patch or on all hair growing areas of a person's body.
For the treatment of underlying disorder, the underlying disorder should be treated including stopping or changing positive type, like a hormonal treatment, oral contraceptive. Oral contraceptive which contain estrogen and progesterone treat hirsutism caused by androgen production. Oral contraceptive are common treatment for hirsutism in women who don't want to become pregnant. For the anti-androgen drug, this type of drug block androgen from attaching to their receptor in your body. They are sometimes prescribed after 6 months on oral contraceptive. If the oral contraceptive aren't effective enough, the most commonly used anti-androgen for treating hirsutism is a spironolactone. The results are modest and take at least 6 months to noticeable. For the other drug like cyproterone, larger dose of cyproterone are combined with the oral contraceptive pill and are very effective for the women with hirsutism. For the topical treatment, depilatory technique. Techniques are generally based on a thioglycolate. A thick layer is applied for 15 to 30 minutes to the hair area, then whipped off and hair comes off with the cream. For the epilation, a beam of highly concentrate light is passed over your skin to damage hair follicle and prevent hair from growing. For the hair bleaching makes excessive hair less obvious. And for the topical, Ifrothrinine is a prescribed cream specifically for excessive facial hair movement. It's applied directly to the affected area of your face twice a day. It helps slow new hair growth but doesn't get rid of excessive hair. Thank you.
Okay, thank you. So for hirsutism and for hypertrichosis, we just have to differentiate the difference between the two. So for hypertrichosis, it is an excessive hair growth in different parts of the body. But with hirsutism, you would actually note that it has a male distribution pattern. So that's just one of the main differences. Of course, with regards to your treatment, first is you should be able to determine the underlying cause. Like for your hirsutism, if one of the problems is your PCOS, of course, you treat your PCOS. While as for your hypertrichosis, so this can be congenital. However, if it is your acquired hypertrichosis lanuginosa, it may signify that you are dealing with an internal malignancy. Hence, you must address the cause. Okay. Continue. Thank you for your presentation.
So, good morning. Our discussion is the common needle disorders. So, first, we have the onychomycosis, also known as Pneumonia, which is a fungal nail infection and most commonly caused by the Trichophyton luteum. This can cause the nails to have yellowish discoloration, thickening, and more likely to crack and break, and also a separation of the nail tear. You can get this infection if you have a history of abscess foot, or in Tagalog, alisinga, or if you walk barefoot and come in contact with soil or water often. You are most likely to develop a fungal infection if you are aged above 65 and if you have diabetes. For the diagnosis, you can take nail clippings and do a microscopic examination or by culture. For the treatment, you can use oral antifungals like terbinafine and itraconazole, but it has a risk of liver toxicity. Also, a topical antifungal can be applied and used alongside the oral antifungal medication to improve efficiency.
For the onychorexis or brittle nails, this is a condition that causes vertical ridges to form on your finger or toenails. Brittleness with breakage of the nails may result from frequent soap and water exposure. Nail polish remover, certain conditions such as your hypothyroidism, anorexia, or bulimia, and even with your oral retinoid therapy. So this certain condition affects up to 20% of the population, women twice as often as men. So, treatment with biotin showed clinical improvement. It is proven that nail plate thickness in patients with treated with biotin increases by 25%. And of course, daily application of your white petrolatum after soaking with water could also be helpful. Treatment for oncorexis depends on the cause, and your dermatologist might prescribe medications to treat the underlying condition, such as if you have anemia, then the dermatologist can prescribe iron supplements or even adjust your current medications. It is also a good idea to use good hygiene and self-care practices to help your nails clean and healthy, so you can wear gloves while you're using cleaning chemicals or washing the dishes, trimming your nails, cleaning your nails, and of course, stopping those bad habits like your nail biting and picking.
So for onycholysis, it is the painless separation of the nail from the nail bed. This is a common problem. It can be a sign of skin disease, an infection, or the result of injury, but most cases are seen in women with long fingernails. This can also be caused by excessive filing, chemical overexposure in manicures or nail tip application, allergic contact dermatitis, or adhesive used to attach the nail tips, or simply to prolong immersion in water. Fungal infection in psoriasis can also cause onycholysis. So the aim of treatment is for the new nail growth or to remain attached to the underlying nail bed. So we must clip the affected portion of the nail and keep the nails short with frequent trimming. We must minimize activities that traumatize the nail and the nail bed. Avoid potential irritants such as nail enamel remover, solvents, and detergents.
So for the next one, we have the nail of lichen planus. So the incidence of nail of lichen planus is 5 to 10%. So fingernails commonly is affected than the toenails. So they may occur as an initial manifestation, especially in children. So nail lichen planus can occur without skin changes, but most of the lichen planus have skin changes in the other location. So they may occur at any ages, but commonly or frequently they occur around 50 to 60 years old. So the most common or the sole manifestation of nail lichen planus would be the 20 nail dystrophy or the tracheonychia. So other changes, as you can see in the picture, are the following. They have irregular longitudinal grooving, which presents or commonly seen with 90% of patients with lichen planus. Ridging of the nail plate, thinning of the nail plate, tridium formation, shedding of the nail plate with atrophy of the nail bed, subungal keratosis, onychopapilloma, erythroonychia, subungal hyperpigmentation, and nail degloving. So the last sign of nail lichen planus will be the partial or total shedding of the nail, and the surrounding skin may also slough. So for the treatment of nail lichen planus, we can do interlesional injection of corticosteroids, So for us to do that, we must do firstly digital nerve block. We can also do topical steroids plus casatorin, and we can also give patient oral prednisone or oral retinoids plus topical corticosteroids. So for the last one, or the most common nail disorder, would be the psoriasis of the nail. So the incidence of the psoriasis of the nail would be around 10 to 78%. So commonly, the affected one will be the older patient who have active exacerbation of the disease. And those patients with psoriatic arthritis are more likely to express the psoriatic nails. So the common findings or the common features that we can find in the patient's nails would be the nail pitting, the view lines, crumbling of nail, leukonychia with rough or smooth surface, splinter hemorrhage, subungual hyperkeratosis, oil spots, and onycholysis. So the severity of the nail may correlate with the severity and psoriasis. Papillus squamous disease may affect the nail similar to psoriasis, with exception of the nail pitting. So in patient, so like for example, Richter disease, pityriasis purpurellaris, Sézary syndrome, acrokeratosis para neoplastica. So for the treatment of psoriatic nails, we can do um, systemic chemotherapy. We can give patient methotrexate, UVA, cyclosporine biologics, and acitretin. We can also do intralesion injection of cinnamon, acetonide suspension, and we can give patient with topical 5-fluorourate.
Okay, thank you. So just to add lang, no, for your psoriatic nail, the most diagnostic sign of your nail psoriasis is your oil drop or your salmon patch. Okay, so remember that oil drop sign. So for your nail disorders, you also have your onychodriposis, your ram's horn nail. So this is due to your thickening of your nail plate. You also have your other nail diseases include your onychomadesis, which is the proximal separation of your nail plate from your nail matrix, and it is due to the temporary cessation of your nail growth, and this can be seen in infection, in fever. So in patients with hand-foot mouth disease, so you can actually see your onychomadesis. What else? You also have your onychocryptosis, which is your ingrown nail. So for your onychocryptosis, the nail edge grow into the dermis. Okay, so periungal dermis. Okay, so sige, we proceed. I think last na ba yung susunod? We have to pass.
Good morning, everybody. We are Group 6 to present common pigmentary disorders of vitiligo, melasma, and onchronosis. Next slide. Next slide.
Good morning, everyone. Under our topic, we have three subdivisions. One is the vitiligo, which is going to presenting by myself, Vital Sushmita, and Douglas Amita. And the second topic is ochronosis, which is going to presenting by Rajanand and Yadav Aditya Prasad. And the third division was the melasma, which is going to presenting by Padrigala Manikanta and Shaikh Abdul Subin. Thus, we go by starting with vitiligo. Vitiligo is an acquired pigmentary anomaly of the skin manifested by depigmented white patches surrounded by a normal or hyperpigmented border due to loss of pigment melanocytes.
For the incidence and epidemiology, the vitiligo usually begins in childhood or in adulthood with a peak onset between ages 10 years and 30 years, but it can occur much earlier in life. About half of cases begin before 20 years old, which is 50% cases. The prevalence ranges from 0.1% to in most countries, but more than 8% in India. According to the clinical features of vitiligo, there may be intermediate tan zones or lesions halfway between the normal skin color and depigmentation, so-called trichome vitiligo. So rarely the patches may have a red inflammatory borders. These patches are various of size and configurations, but the margins are usually smooth and convex. The causes of vitiligo may be by stress and genetically and autoimmune diseases and through the chemicals and sunburns and injuries and by the dysbiosis. And the signs and symptoms are patchy loss of skin color in hands, face, and genital areas, and whitening or graying of hair, and loss of color in tissues that line the inside of your mouth and nose, which is mucous membranes.
For the treatment, systemic corticosteroids, sun protection, supplemented with cosmetic camouflage, self-tanning creams contain dihydroxyacetone, topical pimecrolimus cream, and tacrolimus ointment. For phototherapy, NP-UVB 2 to 3 times a week, oral kilin or L-phenylalanine and antioxidants. Topical PUVA, mini grafting transplantation of analogous epidermal cells, suspension and ultrathin epidermal grafts. And for the diagnosis, blood test to check the health of your thyroid gland. People who have vitiligo often have a thyroid disease. Some diagnostic tests include antinuclear antibody test, complete blood count, and skin biopsy.
This is our final output. Next. So these are the types of vitiligo. Totally is 6. So first we go with universal vitiligo, which is occurs in entire body surface is depigmented. The second one is segmental vitiligo, which tends to present in a unilateral blacklostoid pattern earlier in life and be less associated with autoimmune phenomena. And generalized vitiligo, which is symmetric and affected sites includes face, upper part of the chest, dorsal aspects of hand, axillae, and groin. And for the mucosal vitiligo, depigmenting chronic acquired diseases of the skin and mucosa. And acrofacial, this type affects the distal fingers and facial orifice, the lips and tips. And focal vitiligo affect one non-dermatomal site, such as glands, penis, or asymmetrically affect a single region. These are the pros and cons of the treatment of vitiligo, which is arguments for and against. So treatment, it can be approached in 2 steps, like stopping the progression and depigmenting the depigmented areas. So, treatment like topical treatment, it can be with other drugs, and it can take 4 to 6 months, and 45% of patients see good results. And affordable treatment option and available in many pharmacies. For the cons, which is against the treatment, it is not effective on other body parts, and side effects may include for dry skin, and usually effective on face only, and face only. The second one is poor light therapy. Its for argument is 50 to 75% of patients see positive results, and this is best for legs, arms, back, and face. And the bad ones, like its side effects include skin burns and blisters and even skin cancer. Patients need to receive treatment at least twice a week for a year, and also a priori are not always effective. The cosmetic treatment, the PowerPoint is using makeup to even skin tone is quick and easy. It can rarely any side effects and best for children and carries little or no risk. But makeup is not is affordable, widely available, but does not actually treat the vitiligo. It is a only temporary option as makeup washes off. For the surgery treatment, it can be effective in returning skin to original tone through skin grafting or tattooing, and best for small areas of body. For the against points, the most expensive and the riskiest option for treating vitiligo is not always effective, and side effects include scars and skin infection. Thank you. Next, we move with the second topic, which is achronosis.
Good morning, Doc. So the next is achronosis. We have first endogenous achronosis, that is also known as alkaptonuria. It is inherited as an autosomal recessive trait that is caused by the lack of renal and hepatic homogeneous acid oxidase, also known as NG oxidase. This NG oxidase is necessary for the catabolism of NGA, which is a byproduct of tyrosine and phenylalanine metabolism. The excess NGA is excreted in the urine and deposited in the connective tissue throughout the body, especially in the cartilage, leading to the bluish dark color. As we see in the picture of the eye, that is bluish dark color. The urine is dark and becomes black on standing, and the men to women ratio is 2:1. For many years, the dark urine is the only indication for the presence of alkaptonuria. In the meantime, even the large amount of HGC accumulation in the body tissue, and by the third decade of life, the deposition of the pigments becomes apparent. The early sign is the pigmentation of the sclera and the cartilage of the ears. Later, the cartilage of the nose and the tendons, especially those on the hands, become discolored. For the laboratories, is the evaluation of the elevated level of HGA in the urine, blood, and the other tissue. That is determined by a specific enzymatic and calorimetric test. There is no effective treatment for alkaptonuria. So dietary restriction to tyrosine and phenylalanine is recommended. Joint and cardiac valve replacement can be also necessary. Nitrosamine can greatly reduce NGI excretion, but it does not appear to be effective once the joint disease is present. Tyrosine keratopathy can result from nitrosamine treatment, and the lifespan is not affected by this disease for the patient. Next. So next we have exogenous neurosis. The typically applied phenolic intermediates such as hydroquinone, carbolic acid, picric acid, rescocinol may produce the exogenous neurosis, and even 2% over-the-counter hydroquinone can produce neurosis if used regularly for a long period. The hydroquinone especially inhibit the enzyme Ng oxidase locally instead of the systematic inhibition by alkaptonuria, and this result in accumulation of the blue discoloration on the collagen fibers where hydroquinone is applied. All skin types are affected, but ethnic group with the highest prevalence of melasma and hydroquinone are primarily reported in African Americans, Africans, and Asians. The typical findings are gray brown or blue black macules, usually over zygomatic regions. Hyperchromatic pinpoint papules may also occur that on dermatoscopy are seen and with the associated with follicular opening. Thank you.
Good morning, Doc. Melasma. Next slide. What is melasma? Melasma is a skin condition characterized by brown or blue-gray patches or a freckle-like spots. It's often called the mask of pregnancy. Melasma happens because of overproduction of the cells that makes the color of your skin. It is common and harmless. Next slide. Possible spots for melasma. Melasma typically darkens and lightens over time, often getting the worse in the summer and the better in the winter. Another less common name for melasma is cholasma. Although this disorder is a completely harmless, it understandably makes some people feel self-conscious. Melasma appears the most commonly for your cheeks, nose, chin, above the upper lip, and the forehead. It sometimes affects your arms, neck, and back. In fact, the melasma can affect any part of your skin that is exposed to sunlight. Next slide. What happens in the skin? Your epidermis contains the cells called the melanocytes. The store and the produce a dark color pigment known as the melanin. In response to the light, heat, or ultraviolet radiation or by hormonal stimulation, the melanocytes produce the more melanin, and that's why your skin darkens. Melasma is a very common skin disorder, especially among the pregnant women. 15% to 50% of the pregnant women get it. Next slide. What are the types of the melasma? Epidermal, dermal, and mixed melasma. Epidermal melasma has a darkened brown color and well-defined border, appears obvious under the black light, and sometimes the responsible to treatment. And dermal melasma has a light brown or the bluish color and blurry border, appears no differently under the black light. It doesn't respond to the well to treatment. A mixed melasma, which is the most common for the three, has both bluish and the brown patches, shows as a mixed pattern under the black light and shows some response to treatment. Next slide. What causes melasma? Causes of melasma: excessive sun exposed to harmlight, hormonal changes, stress, thyroid problems, and medications. There are two main causes of melasma: radiation, whether the ultraviolet visible light or infrared heat light, and hormones. Ultraviolet and infrared radiation from the sun are the key in making the melasma worse, and other possible causes of melasma include the contraceptive therapy, lead screens, and the hypothyroidism, and makeup, and phototoxic drugs, etc.
What are the signs of melasma? In the melasma appears in 6 locations, a combination of location on your skin. brachial, centrophageal, lateral cheek pattern, malar and mandibular neck. Next slide. Symptoms of melasma. Melasma causes patches of discoloration. The patches are darker than your usual skin color. Typically occurs on the face and is symmetrically with matching marks on both sides of the face. Other areas of your body that are often exposed to sun can also develop melasma. Brownish colored patches usually appear on the cheeks, forehead, bridge of the nose, and chin. Next slide. And side effects are skin irritation and darkening of the skin. Next slide. And diagnosis in test. Visual exam of the affected area is often enough to diagnose melasma. One test technique is the wood lamp examination. This is a special kind of light that held up to your skin. It allows your healthcare professional to check for bacterial and fungal infections and to check for any serious skin conditions. They might also perform a biopsy. This involves removing a small piece of the affected skin for testing. And treatment, melasma can lead fade of its own. Hydroquinone, this medicine is a common first treatment for melasma. It is applied to the skin and works by lightening the skin. It came as a cream, lotion, gel, or liquid. Tretinoin, and corticosteroids that helps to enhance the skin lightening, and azelaic acid or kojic acid to help lightening the skins. Thank you.
That's the last presentation, right?
Yes, Product.
Okay, thank you for your presentation. So just the difference between your ochronosis and your melasma. Of course, for your ochronosis, we have your endogenous type, which is associated with your alkaptonuria, and you also have your exogenous type, wherein it is caused by your hydroquinone, more than 4% of your hydroquinone solution or therapy. So one difference is for its morphology. You would actually notice that your ochronosis is more well defined as compared with your melasma, which is ill defined. And then for the areas of predilection for your ochronosis, usually would see that on the malar area, on the temple, on the lower cheeks, on your posterolateral neck, your back or your extensor, while as for your melasma, you would actually notice that it's located on the centrofacial area. So you have your forehead, your nose, your chin, your upper lip, and you would note that it would spare your periorbital skin, your lips, your neck, and your ears. Both can be treated with your Kligman's therapy. I think you did not mention that. However, that is a combination of your hydroquinone, of your tretinoin, and your topical steroid. Okay, anyway, I will be sending my report for your disorders of pigmentation. And I think that's it. We can end early. Thank you for presenting your infographics, and thank you for your cooperation. So for your exam next week, madali lang as long as you've listened today. Okay. Most of the questions naman were highlighted. Okay. So the scope, that is for your finals, di ba? I think it's 100 items. So for the scope, yung lecture ko lang. So from the time that I started my lecture, ano ba yun? Nasa the tumors, up to yung asynchronous na isa-send ko later. Okay. So, madali lang if you've listened. Kasi I highlighted naman those that I will ask sa exam. So, if you're listening, hindi mahirap. Okay? Same with your, I don't know if you're done with your pedia exam, but if you've listened to the lecture, yung video lecture, andun din lahat. So, pakinggan nyo na lang yun. I think I also highlighted the questions that I will be asking. More of contrast.
comparison and contrast para mas madali nating ma-memorize, mas madaling grasp, mas madali yung pasok ng information. Kasi pag diniscuss natin siya as isa-isa, usually you would not see the differences of these disorders. Mas madali pag side by side, okay? So, any questions pa? Thank you for the infographics kahit kahapon lang ata ginawa. Galing. Okay, I think mag-attendance check muna ako. See you for your pedia exam sa Wednesday. Pedia lecture, sorry. Wait lang. Share screen lang. Share screen, sorry. Screenshot. Thank you. I hope I made some of the topics easier than it is. And thank you. Good luck. Bye.